Hello everyone. In this series, we'll talk about altered mental status. These are possibly the most challenging patients that you will encounter as your history is very limited and there is not much interaction with your patient. We'll go step by step and understand how to evaluate these patients and how to reach a diagnosis. This is a large and complex topic, so it will take a few lectures to complete this. Some lectures may be longer than usual. These lectures are by no means complete. My goal here is to give you a solid base on which you can build up and you can feel more comfortable when you encounter these patients. To begin with, altered mental status is a symptom, not a disease. So you have to find an underlying cause for mental status change. The altered mental status term has to be qualified. There are different types of arousal states and you have to understand the difference between each and try to be more specific when you present on the rounds. So you can have comatose patient and these patients are unarousable. You can have stuporous patient. These are unresponsive but can be aroused by stimulation. Patients can be lethargic. That means they have decreased mental alertness and drowsiness. Delirium refers to acute confusional state, which can be both agitated or drowsy. Dementia means memory loss. So use your terms to qualify what kind of altered mental status that you are referring to. Next question is, what keeps you awake and conscious? And the answer to this is more complicated, but in short, you have ascending reticular formation in your brainstem and the impulses from this are relayed through thalamus to your bilateral cortex. And this axis controls the sensory processing and understanding, and this generates awareness. This axis keeps you conscious. The areas of ascending reticular formation and thalamus are very dense in the nerve population, so you only need small areas of involvement in these two places before you become comatose. However, you need bilateral cortical dysfunction to become comatose. For example, if you have a stroke, you will have a focal areas deficit, but this will not cause mental status change. However, as the time progresses, there will be more cerebral edema and worsening focal deficits, and this will, in some patients, result in midline shift and compression of the other cerebral hemisphere. Now you have got bilateral cortical dysfunction because one side is inflamed and other side is compressed by this inflammation, and now patient will be more altered. There are 3 steps to figuring out what's going on with the patient. First is history, second is neuro exam, and third is your lab and radiological testing. The goal of the history is to figure out what's causing the altered mental status. If you do not get a good history, you will find yourself ordering a multitude of tests to figure out the underlying problem. So history is the most important part in evaluation of altered mental status. Always ask a family member, a bystander or EMS who was the witness to get some more information. A lot of time there is no family members around, so try to find a phone number and talk to some family members to get some idea about what happened. This will be possibly more beneficial than any examination or test findings. Step 1. Try to get an idea about time course of altered mental status. And here you have to figure out when they were seen normal last time. You can go back history in hours, days or weeks to figure this out. And what you're looking for is, was the altered mental status sudden, gradual or fluctuating? If you have sudden onset, this will be seen in acute stroke, subarachnoid hemorrhage, poisoning, etc. Gradual onset altered mental status will be seen in infection, organ failures, while fluctuating can be seen in patients with recurrent seizures and delirium. Next, find out what preceded altered mental status, and this will give you a clue to underlying etiology. You can see fevers in patients with meningitis, encephalitis, sepsis or certain drugs. Patients can have headache in subarachnoid hemorrhage, intracranial hemorrhage, meningitis, etc. Ask for focal deficit in motor or sensory areas, speech or vision. Ask if there was confusion preceding altered mental status, and this would lead you towards sepsis, drugs, or medications. Ask for seizure activity, and was there any falls or trauma preceding altered mental status. Try to figure out if there is history of substance abuse, suicidal ideation, was there any recent hospitalization, and try to figure out underlying medical conditions, for example, cirrhosis, COPD, diabetes, history of strokes, seizures, etc. Try to figure out what their baseline functional status was. Many patients with poor baseline functional status do not require much to become altered. For example, a patient with cerebral palsy can become altered by a simple UTI. Always do a medication reconciliation and try to see if there were any recent medication changes. Make note of medications that can affect the mental status, and understand that medications can accumulate in renal and liver diseases. Also look for compliance for these medications, as withdrawal of drugs can also result in altered mental status. Try to frame your questions in your history to figure out the underlying etiology. There are 5 main reasons for altered mental status, and as we learned before, anything that would affect your reticular activating system, thalamus, and cortical axis can result in altered mental status. So the big ones are drugs or ingestion. Next are structural brain lesions, sepsis or infection, organ dysfunction, and seizures. Structural brain lesions can be seen in patients with trauma, cerebral vascular diseases or accidents, tumor, anoxic brain injury, etc. Organ dysfunction, for example, hypoglycemia, myxedema, or additions in endocrine system, hypercapnia in respiratory, hyperammonemia in hepatic, uremia in renal, and hypotension in cardiac, can result in diffuse neuronal dysfunction and result in altered mental status. Etiologies such as drug ingestion, trauma, cerebrovascular accidents, cardiac arrest, seizures, and hypoglycemia will present more acutely, while other organ dysfunction, sepsis, would be more subacute. Sometimes there may be more than one etiologies. Always get an insight of a family member and ask them what they think would have caused this mental status change. Many times this will help you figuring out what's going on with your patient. Prognosis of altered mental status depends upon underlying cause, so take a good history. In summary, altered mental status is not a diagnosis or disease. Try to figure out the underlying etiology for altered mental status. Disruption of ascending reticular formation, thalamic and cortical axis result in altered mental status. Small areas in brainstem and thalamus can result in altered mental status, while you need a large areas of cortical involvement to become altered. History is the most important part of AMS evaluation. Make sure that you talk to family, bystander, or EMS when you admit a patient with altered mental status. Get a timeline of symptom and ask questions to rule out or rule in your differentials. Always ask the family members what they think would have caused this. In next lecture, we'll learn how to examine these patients. Thank you.